Sir, can we start now? Sir, can we start now?
Yes, yes.
Sir, can we start now?
Yes, you can start. You can start with the introduction.
Yeah. Just a minute, sir. I can just go. Hello. Good evening, sir. Good evening, Dr. Ankur Gahlot. And I just welcome to all our delegate all my our delegates who have joined this session. So first of all, I just welcome to each one of you in this wellness virtual class. So as all you aware that it's our privilege that Dr. Ankur Gahlot has joined us today. And Dr. Ankur Gahlot is a big name, especially in the endocrinology. Sir is work right now currently working in the Rukmani Bedna Hospital. Dr. Ankur Gahlot is a renowned endocrinologist in the India. Dr. Ankur Gahlot is currently working as a additional director, Department of the Diabetes and the Endocrine Society, especially in the Rukmani Bedna Hospital. Sir has done his MBBS, MD, and also in the DM endocrinology from the BHU Varanasi. Sir is having the more than 15 years of the experience in the endocrinology. Previously, Sir is associated with many hospitals, especially in the RML Hospital, Delhi, Safdarganj Hospital, Delhi, and also Sir is associated with the Fortis Hospital, Jaipur itself. Sir is associated with the many publications, scientific paper, and also the research paper itself. Many recognitions and rewards are also connected with the sir. Sir is also received the M. Chenna Reddy Award for the best paper, and Sir is also associated with got the best paper award, especially in the Econ Valor 2010. So today's, as all you know, that the topic of the today, the age related changes in the glucose metabolism, and Sir is the very having the very deep knowledge, especially in that particular topic. Sir, now I'm just handing the session to you. So please guide all our delegates so they will enlighten and get some new guideline and some new things from this topic itself, sir. Hand over to you, sir.
So, hi, good evening, ladies and gentlemen. I'm Dr. Ankur Gahlot, and I hope my slides are visible. Can you see my slides?
Yes, sir. Slides are visible, sir.
Okay, fine. Good evening, everybody. I would be talking very interesting topic for today's meeting, that is age-related changes in glucose metabolism. And as we can see, the recent data from various studies, that the prevalence and incidence of not only diabetes but pre-diabetes is going very high. So just a minute. Yeah. And we know that aging and diabetes are two well-known risk factors as far as cardiovascular disease are concerned. And aging alone is associated with a decline in physiological functions, which leads to chronic disease in form of diabetes, chronic vascular disease, cognitive dysfunction, as well as physical disability. And diabetes is the most recognized cause as far as aging or acceleration in these things are concerned. So the mechanism which links advancing age to metabolic dysregulation are obviously multifactorial and complex. Asymptomatic hyperglycemia occurs in many people when they age, and it creates an incidence or a progressive metabolic dysfunction or dysregulation. Altering the trajectory of pathology by lowering mean plasma glucose levels may not be possible owing to a permanent vascular changes as far as type 2 diabetes is concerned. If you really see humans living longer, obviously life expectancy has been increased drastically over past centuries, more so in countries like India. and this trend is occurring worldwide, even faster in developing countries.
Sir,
Aging
sorry
by,
to
of course,
interrupt, sir.
the
Slides, sir, are not visible, sir. Slides. Please
okay,
share it again, sir.
okay, I'll do that. Mm, just a second. Uh, uh,
Otherwise,
I'm
I will share the slides, sir, from here.
No, no, actually, I am not able to see the sharing
Share
screen.
button is in the middle, sir. It is green
Yeah,
color.
I know, I know, I know. Just a second. Yes, I got it.
Yeah.
I got it.
Now visible, sir.
Now visible?
Yes, sir.
Fine enough. Uh, so as we know that age-related changes in glucose metabolism is there, and what happens is as our age goes increasing, two things happen. Number one is the insulin resistance. So the insulin sensitivity start decreasing and insulin resistance start increasing. And there is some deterioration in the beta cell function also. The insulin secretion for the beta cell is which is tightly coupled with the availability of glucose, thus allowing a fine tuning of blood glucose level within normal range. And there is slight beta cell dysfunction also starts happening. In healthy individuals, we know that skeletal muscle is very sensitive to insulin and can increase its uptake up to 85% of the circulating plasma glucose with a sudden increase in plasma glucose. With age, some patients, some individual progressively lose the ability to regulate glucose level as they did when they were even younger. So the effect on the effect of age on the peripheral vascular metabolism or peripheral glucose uptake, and we know that there are two mechanisms of glucose intake. That is, one is insulin mediated glucose intake, and other is non-insulin mediated glucose uptake. So insulin mediated glucose uptake preferably occurs in the muscles as well as fat tissue, while non-insulin regulated uptake occurs in brain as well as the splanchnic organs, that is the GI organs. So in fasting state, we know that insulin utilization occurs mainly in non-insulin mediated glucose uptake tissues such as brain, which take up around 50%, splanchnic organs which take 20%, and the muscle and the adipose tissue hardly takes 20% with each. In postprandial hours, the glucose uptake is chiefly insulin mediated, which is mainly by the skeletal muscle as well as by the adipose tissue also. So there are two types of so as well as the same is with the insulin secretion. So as we know that insulin secretions occurs in a pulsatile form, and there are two important pulses. One is the rapid low amplitude pulse, which is important in inhibiting the hepatic glucose production and preventing insulin receptor downregulation. And then there is the second pulse, which is more responsible for decrease in the glucose in postprandial hours. So in healthy non-obese individuals, aging is associated with a decrease both in the amplitude as well as the mass of the rapid insulin pulses, and there is reduction in the frequency of ultradian pulses during the fasting state. With stimulated by sustained hyperglycemia for 10 hours, there is a reduction in the mass and the amplitude of the rapid pulse. So ultimately, what happens is the pulsatile secretion of insulin is decreased both in amplitude as well as in the frequency in a healthy non-obese individual as there is a aging. So what happens is on one side there is slightly increase in the insulin resistant, and on the other side there is slight decrease in the insulin secretion, and that is the responsible for the glucose intolerance as well as impaired fasting plasma glucose in elder individuals. And we know that after age of 60 years, the incidence of not only pre-diabetes in form of high fasting, or pre-diabetes in form of deranged postprandial glucose is increased exponentially. So, in addition of overconsumption of food, older individuals may likely be more predisposed than younger individuals to gain weight. We know that there is a gradual loss of muscle mass, and there is a gain in fat mass starting with the fourth decade of life. Then, in menopausal women, with the decline in testosterone in men's also, which ultimately responsible for the loss of muscle mass as well as the gain in the adipose tissue. Then catecholamine induced lipolysis in adipose tissue, which gets blunted in older individuals as age progressive. Regarding the diagnostic criteria for older individuals, ADA 2025 and World Health Organization, they have a similar guidelines as far as the glycemic criteria for diabetes. So any random sugar more than 200, fasting plasma glucose more than equal to 126, 2-hour postprandial glucose after 75 gram oral glucose tolerance test more than equal to 200 milligram per deciliter, or HbA1c more than equal to 6.5. So the criteria for pre-diabetes and diabetes remains same irrespective of the age of the individual. So even in the elder individuals, the criteria will remain same. What should the target be? So obviously, as far as glycemic control is concerned, our target should be individual based, based on the age of the patient, of course, as well as the clinical characteristic and the comorbid condition. So how do people individual targets or goal for HbA1c is obviously around 7%. Men should be more aggressive targets than women. Avoid hypoglycemia and hyperglycemia both at all. Regarding the determinants of glycemic control in elderly individuals. So on one side, in the elderly individuals, we have a high risk or propensity of hypoglycemia. Then there are presence of multiple comorbidities. Then there is presence of or the risk of falls and the fracture, disabilities, functional impairment, presence of polypharmacy, already taking multiple medication. Then there could be short life expectancy also. So ultimately, we should be less stringent as far as glycemic control goals are concerned, because if we target a more stringent goal, that is HbA1c of 7, then of course, number one, we have to give high or more number of medications or in a higher dose, or number two, there would be higher risk of hypoglycemia. And because of this, the goals in elderly individuals or elderly patients should be flexible. So any HbA1c between 7.6 to 8.5 could be fine in with these individuals. Our goal should be to prevent any symptomatic hyperglycemia with lesser or least risk of hypoglycemia with HbA1c between 7.6 to 8.5. So these are the reasonably okay goals. If you really see the treatment goals in individuals or adults with more than equal to 65 years of age, then ADA 23 says that any goal around 7.5 or less than 7.5 is okay. In a patient with complex or intermediate health problems, in which three or more than three comorbid conditions are present, there is mild cognitive impairment, the quality of life impairment is more than equal to 2, there is increased risk of hypoglycemia or high treatment burden, or there is a risk of fall of risk, any HbA1c less than 8 is absolutely okay. Obviously, individuals with very complex or poor health, where the long-term care has to be taken care of, the moderate to severe cognitive impairment is there, and stage chronic illness are there. Then obviously, not a single HbA1c is not recommended, but any HbA1c around 8.5 or less than 8.5 to 9 is okay. The goal is to avoid hypoglycemia as well as symptomatic hypoglycemia. So for these individuals, strict goals are not to be followed. The only goal is to avoid hypoglycemia as well as symptomatic hypoglycemia. So why do we think of about the different targets in frail individuals? Obviously, we are afraid of hypoglycemia. And hypoglycemia is obviously sometimes it is unable to recognize and treat, especially in elderly individuals, because they don't they are not in condition to report the symptoms of hypoglycemia because of their cognitive dysfunction. They could be treatment under treatment because of the fear of hypoglycemia, and obviously there is risk of skipping the insulin dose to prevent the risk of hypoglycemia. So the risk factor for hypoglycemia is obviously misadventures according to meal planning. So we sometimes take too much of our efforts in making the meal planning for elderly individuals without looking into the practical implications. So we should not do that. And on the other side, we should not prescribe a complex insulin regime to elderly individuals. So the for more individuals who are more susceptible, especially those having age-related changes, cognitive dysfunction, polypharmacy, and change in the counter-agonist response, we should be very stringent about advising complex insulin regimes. Then hypoglycemia can cause significant morbidity on itself. It can provoke a major vascular event in form of stroke, MI, or ventricular arrhythmia. A severe hypoglycemia can be debilitating with the increased risk of injury or fractures. Symptoms may be different, unsteadiness or weakness, but it have a very negative effect as far as confidence of the elderly individuals are concerned. The manifestations of hypoglycemia may be mistaken as TIA or vasovagal episodes. So we have to be very stringent regarding the symptoms as well as monitoring of hypoglycemias. Older individuals have a higher probability of needing insulin, have a higher risk of CV events if postprandial glucose are not managed. So before starting insulin, you should evaluate whether patient is physically as well as cognitively capable of taking insulin, administrative insulin, able to monitor his blood glucose and recognize and treat hypoglycemia. So you have to be very sure that patient is able to do all these things. Then only you start of thinking about starting insulin as a treatment regime for this patient. Most trials on insulin therapy in type 2 diabetes on elderly individuals, and you can very well see, if you really see the pharmacological summary of all the anti-diabetic agents, then of course you can use metformin, pioglitazone, GLP-1 analog therapy, because these has a very low risk of hypoglycemias. But obviously there are certain side effects, as a GI side effect for GLP-1 analogs and metformin, renal problems with metformin, and of course a risk of heart failure with pioglitazones. But apart from that, these three therapies carries least risk of hypoglycemia. While for gliptins and SGLT2 inhibitor, the risk of hypoglycemia is low. While you have to consider the dose of gliptins as well as SGLT2 inhibitor according to the estimated GFR. Sulfonylurea carries a moderate risk of hypoglycemia, especially in patients who are very elderly, and the dietary pattern of these patients are very erratic. For these patients, you have to be very judicious about using sulfonylurea. Interaction between diabetes and geriatric syndrome, we know that diabetes is associated with mental health problem in form of dementia and depression, while physical health problem in form of sarcopenia or fragility. And ultimately all these factors, when they are occurring together, they leads to a worsening of diabetes control. Frailty is seen as a major risk factor for death, should be taken as a part of routine review. Intensive glucose monitoring should be limited for benefits and may be dangerous for older frail patients. Fragility index should be taken care before starting any kind of treatment for these individuals. Regarding pharmacokinetic and pharmacodynamic changes with agents, we know that there is reduction in the renal and hepatic functions with increased age. There is increased volume distribution of lipid soluble drugs, increased drug half-life. The drug accumulation also occurs in circulation, intensify the sensitivity to the drugs also. So we should be very cautious in elderly individuals, because the drug response or the dose response should be erratic. Then there are physiological changes affecting medication in elderly with diabetes. So we know that the slow peristaltic movement leads to a longer exposure of medication to GI tract, like metformin and carbos. Decreased hepatic metabolism or blood flow can slow the elimination of drug metabolized in liver, like nitaglenides. Decreased renal blood flow and increased duration of action or potential for toxicity, it can happen in case of sulfonylurea, insulin, or metformins. So obviously avoid the drugs with high risk of hypoglycemia when possible. In patient with cardiovascular disease, heart failure, and chronic kidney disease, always consider the risk versus benefit for GLP-1 receptor analogs or GLP-2 receptor SGLT2 inhibitors. Use caution with or without avoiding the risk. Especially with the SGLT2 inhibitors, because these in some patients it can lead to recurrent genitourinary infection, hypotension, or even euglycemic ketoacidosis. GLP-1 analog should be also used with caution because the history of pancreatitis, gastroparesis, and unexplained weight loss. So if you really see treatment algorithm as far as elder individuals with type 2 diabetes, age more than 75, the recommend drugs. Obviously, the most common drugs can be either metformin or DPP-4 inhibitor, or you can use basal insulin in some patients. Step 2, you can add on DPP-4 inhibitor, or you can add other insulins also. You should avoid sulfonylurea, glinides, pioglitazone, SGLT2 inhibitors, and GLP-1 receptor analogs, especially in patients who are frail or who are having a lesser, you can say, cognitive cognition, or there is moderate to severe dementia. In these individuals, you should try to choose the drugs which leads to lesser risk of or least risk of hypoglycemia, easy to take, and with lesser risk of side effects. This is the algorithm for if you are taking care of patient with who is in the last few months or weeks or days of his life. Then always don't use complex regimes. Always use simple regimes. Do not target a euglycemia or a sugar of or random sugar less than 180. But you have to avoid symptomatic hyperglycemia, because with symptomatic hyperglycemia there would be increase in the glycosuria, and there would be polyuria, and that could create a problem for these individuals. So key points for treatment of diabetes in elderly individuals is obviously treating type 2 diabetes in geriatric patient requires a assessment of a multiple factors. Individualized treatment goals based on the patient risk factors or the patient comorbid condition is essential. Then we should discuss risk versus benefit for newer type 2 diabetic agents, especially in elderly individuals. And you should use a shared decision making to guide the therapy. The goal for therapy in these individuals should not be only the glycemic control or the glycemic efficacy, but the goal should be a comprehensive control which can take care of symptomatic hyperglycemia without or with minimum risk of hypoglycemia, a simple regime in which there is less chances of side effects, as well as the errors in the dosing. Thank you all. That was presentation from my side, and I would happy to answer if there are any questions, please.
Thank you, sir. Thank you. Thank you for your guideline and enlighten all our delegates. Few of the questions which we have received on our portal, I just ask on the behalf of all our delegates. The first question is exactly that. What is your, sir, your opinion regarding the inhalation insulin, especially in the elderly patients?
Look, I'll say one thing. Number one, it's it's trial on elderly individuals. I am not aware of. Number one. Number two, inhaled insulin is still to be marketed in India. It is still not available. So we have to see what kind of insulin or what kind of insulin requirement is there for the elderly individuals. Because for inhalation insulin, one thing is very difficult to assess is that the whole inhalation is going through the oropharynx and the nasopharynx. So also if patient is having some nasopharyngeal condition, it can impair or it can hamper the absorption also. So it would be very difficult to tell what could be the effect on elderly individuals. First, we have to see its effect on younger individuals.
Thank you, sir. The another question is that if any person or the patient is not following the stringently HbA1c goal, so are we not exposing the patient for the macrovascular complications?
Yeah, of course. Look, one thing is very important to understand that poor glycemic control and its relation with macrovascular complication is only relevant in long-term basis. So if you really see, the only study which has shown that a intensive glycemic control was translated into a better macrovascular outcome, cardiovascular outcome was there in UKPDS trial. And UKPDS trial in the individuals, it was started from the diagnosis of diabetes. So once we talk about long-term management of diabetes, then of course a intensive uh, control is associated with a good cardiovascular risk factor. But for elderly individuals who are already more than 70 or 75 years of age, our intensive glycemic control is of no use, because intensive glycemic control can lead to hypoglycemia, and that hypoglycemia can lead to a cardiovascular risk in form of arrhythmias or heart attack. So that we should not do.
Okay, sir. Sir, the another question is that that you have told that only the HbA1c measurement is sufficient, especially for all the diabetic patient. So, does all the delegates just want to know that the random glucose level checkup is also required, or only the HbA1c is sufficient?
No, no, I think both are required. Both are
Both
required.
are required.
Because what
Okay.
HbA1c tells us is about a hyperglycemia of past, that is in last 100 days. That is around 3 months.
Yes, sir.
But that does not tell us that what is the sugar right now. So obviously HbA1c is also important, and sugar is also. HbA1c, you can only diagnose HbA1c according to you can only diagnose diabetes with HbA1c,
Yes,
but
sir.
without knowing the sugars which is present right now or today, you
Yes,
won't
sir.
be able to start any treatment. And that is the reason why you should get both HbA1c as well as random or fasting BP sugars.
Yes, sir. The one last question exactly which we have received that that is sir, you have discussed about the age related glucose metabolism. Uh, does how's the lifestyle is also impacting this glucose metabolism more, or the
Yeah,
age is
obviously,
impacting more?
because when someone starts aging, the obviously the physical activity start decreasing, and
Yes,
because of the decrease in the physical activity, there is tend to be weight gain. Number one,
yes,
number two, the insulin dependent glucose uptake in the muscle is also decreased, and in various organ it is also decreased. And on the other side, there is diet problem also. So these are the peculiar problems which are there with the elderly patients or associated with aging, and that is the reason why dysglycemia or pre-diabetic prevalence is very high in elderly individuals. In fact, in some studies, it has been seen that after the age of 60 or 65 years, the incidence of pre-diabetes and diabetes is even more than 50%, and that is the part and parcel of aging that we have to understand.
thank you, sir. Thank you for your guidance, and you have enlightened and give the your valuable speech to all our delegates. Thank you, sir. On the behalf of all the delegates and the Corona remedies, we just again thank you to all to you, sir. Yeah.
Okay, bye bye, good
Bye
night.
bye. Bye bye, sir. Thank you, sir.